Okay, hello everybody. My name is Clemens Kösters. I'm an orthopedic surgeon from Germany. I'm working in Greven. It's a small town near to the university town of Münster in West Germany. And I'm an Episealer user since 2016, or right since then I used the Episealer implants. And first of all, thank you very much, Episurf, for the kind invitation to this big event and to let me have a presentation on my results and on my treatment with the Episealer implant for multiple lesions. So I would like to start. That's what I already said. Why should we implant 2 or 3 patient-specific implants in one knee? Why shouldn't we go for total knee and that's it? So we have many middle-aged patients, or sometimes we say best-aged patients. Yeah, patients in the age of 40 to 60, and they are healthy. They are doing a lot of sports, and they have high demands on their free time. And when they have pain in the knee and they can't do their sports anymore, they have a big problem, and they want to have a change. But on the other hand, many of these patients don't want to have a total knee, because a total knee is not always working fine, as we know, and all the patients are well informed in these days via internet, and so they know that not every total knee is working really fine. So they are too young for a total knee, because if we implant a total knee with the age of 40, many of these patients need 2 or 3 revisions in their whole life. And what we also could do is a biologic cartilage repair, as you can see in this image here below. That's the AMIC technique, where you drill holes in the bone, and via the blood clot there is regrowing new cartilage. But this is a problem, because in the middle-aged patients, these techniques don't work as fine as in, for example, young, like 20 years old patients. So this is one reason why the Episealer implant was developed. And here you can see a damage report of a knee that has not only one area of cartilage defects, but 2. One in the so-called patellofemoral joint. This is here where the patella is gliding on, and on the medial part of the knee. And there we did an Episealer implant for 2 areas. Here you can see the drill guide that allows a very exact implantation. And here the implant of the trochlea prior implantation and after implantation. So this is the X-ray after the operation. Looks very fine. And now, how do I decide which patient is suitable for this technique, for 2 or 3 implants? So again, middle-aged, or let's say best-aged patients. No malalignment. That's important, because malalignment, we all know, leads to a severe osteoarthritis. So we shouldn't do this in patients with a varus or valgus malalignment. The patients shouldn't be obese, and the range of motion of the knee should be also okay. And then in my daily practice, I nearly do in every patient an arthroscopy to see if the tibial cartilage is really fine, because this is very important. The cartilage should be fine on the tibial part. An exception for me is the retropatellar cartilage, so the cartilage of the patella. That shouldn't be fine, in my opinion. It could be damaged. But in the tibial part, where you walk on, these areas should be fine, and the meniscus should be intact. So that's what I want to check. And then I think we could reach results like we know for the single Episealer implants. You maybe already heard the results of this 2-year results study that we did on a cohort of 80 patients, and that was really impressive how good the results were. So My question was, can we reach these results also for 2 or 3 Episealer implantations? And so in Greven, we already operated many of these patients, and we included the first 32 patients in this prospective study. And there were 23 patients with 2 implants and 9 patients with 3 implants. And you see a mean age of 53 years and a mean body mass index of 27. And here you see 2 images of patients with these multiple lesions. And this was the aggregated KOOS score. That's the score that shows you the results for functional outcome of the patient, what can they do, but also pain. And so here we can see a very low amount in the preoperative questionnaire. And then after 24 months, we have a very good result. And this is again shown the KOOS score, but in the subdomains like pain, activities of daily living, sports. And also here you can see after a 24-month really nice result. Here you see this again, a little bit different, but also here nice results. And then very important, pain is the most important thing for these patients. They have pain and they can't do sports, so they want to have no pain. And here you can see that if you see the preoperative pain, it's more than 6. That's really severe pain. And after 24 and already after 12 months, you have a really nice reduction of this pain. And here you can see single and multiple implants in one graph. And we can see that the 2 or 3 implants are not that worse than the single implants. And that's what you also can see in the subdomains of the KOOS and also for the pain. So, and if you see on the 2 implants versus 1 implant, you even can see that the pain was reduced even more in the 2 implants. Okay, let's say it's not a study with thousands and thousands of patients. It's a small number, okay, and it's until now a short follow-up and single center data. But in the end, I think it's showing good results, and it's we could be very hopeful that it's also with more patients the same. And now I would like to present you a case of a 43-year-old lady. She's a professional fitness coach, and she had an ACL reconstruction 15 years ago, and she came to me with consistent pain under full weight bearing when she was doing her sports courses, leading her sports courses. And one of the first things she told me was, I don't want a total knee. What can you provide me? So that was good. We did our diagnostics. We always need these standing x-rays to see if we have a malalignment. She has no malalignment. And here you can see that the medial and lateral part was not osteoarthritic in this left knee. And here you can see the MRIs of this lady, and you see areas with cartilage defects in both condyles. And if you see it from the lateral view, you can see here cartilage defects and also bone edema here in these areas. And maybe if you see such MRIs, I think 90% of my colleagues would go for a total knee, because they say in all 3 compartments of the knee there are severe cartilage defects, so we just implant a total knee. But the patient again is 43 years old, very sportive, and she doesn't want a total knee. So I told her, okay, let's have a look what we can do. And there's this new technique from Sweden. And now we did this Episurf MRI, and we had a look on the damage report. And when you see this, you maybe are a little bit concerned, because you see red areas where there's no cartilage. But the thing was that on the tibial part, most parts of the cartilage were fine. Only in this damage report, you can see one small area in the lateral tibial condyle where you are a little bit afraid about more than grade 2 cartilage defects, and that would be a contraindication. So I decided to do an arthroscopy, and here you can see the video about it. This is the medial part of the knee, and you see cartilage defects in the femur, but the tibial part was fine, and also the meniscus was fine. And this is lateral view, and here you can see that the tibial cartilage was not that damaged as we have seen it in the damage report. So maybe sometimes in these cases, here you can see the femoral lesion, we should go for an arthroscopy and to be sure that that it's possible to implant such implants. And here again, this is the femoral part on the lateral part of the knee, and you can see that here down the tibial cartilage is not that bad as we expected from the damage report. So I decided, here you can see the trochlea with quite big lesions, but in the end we talked and we decided to do an Episealer, because what are your options in the end for these patients? You could try a biological repair, but she said, I cannot do 6 weeks of partial weight bearing because I have to work. I earn my money with my sports courses, and I have to do these courses. And so these options are not suitable for this patient. And again, she doesn't want a total knee. You can implant very nice total knees like this custom-made total knee from Symbios in Switzerland. Very nice, I like it. But in the end, I think it's for her not suitable. And if you see here the treatment options in this slide, for the young patients, it's no problem to do a biological repair with good results. But for the old patients, we can do a uni or total. But if old is 40 years, I feel very old because I'm 46 now. So, and in my opinion, the middle-aged patients, they have a chance to get this Episurf in this area between the old and the young patients. And also we have a chance to implant Episurf, Episealer implants in patients that maybe have tibial good cartilage or fine cartilage. And so we could avoid a total knee in rare cases, also if we have 2 or 3 parts of the knee with severe cartilage defects. Okay, she said, I said it sometimes, I don't want a total knee. Okay, and so we implanted these 3 nice implants. Here you can see the intraoperative image, very nice and patient-specific implants. And that's the postoperative view. And this is 20 months after the operation. And here you can see the standing X-rays, 20 months on the right side, 20 months after surgery. And there was no narrowing of the medial joint space that would be a sign for osteoarthritis. And she was fine. And that's the video 2 weeks ago. I've seen her in my outpatient unit, and she was really happy because she was already doing her spinning courses and other courses that she was giving in her private practice. So she was very happy with this, and I think such a function is really good, a really impressive result. And I don't know if we could reach this with a total knee. And on the other hand, if these implants maybe fail in 10 or 15 years, it's not a problem to implant a total knee. Okay, so we have opportunities with these mini metal implants, but maybe also risks. So now I would like to present you a borderline case maybe. It's also a quite young guy. I know him personally, and he had this arthritis in the medial part, medial osteoarthritis. And I wanted to do an osteotomy because he has a varus knee. And then I did an arthroscopy, and I've seen cartilage defects also here in this lateral femoral condyle, but the tibial part was fine. So he had this varus, as you can see here. It's the left knee. And that was the image from the arthroscopy. Here you can see the cartilage defects on the medial part and in the trochlea. But the lateral part the tibia was fine, the meniscus was fine, and there was only this focal lesion in the femur. So we did an MRI, Episurf MRI, and we have seen these lesions. The medial part is the osteoarthritis, and here the other red areas are the fourth grade cartilage defects. So we planned these implants, and we did an implantation. And this was the arthroscopy when we did the second operation, and the second operation was an osteotomy to correct the malalignment. So here you can see a very nice implanted episealer in the trochlea, and now you see it here on the lateral part. Again, here you can see it, very nice. You see overgrown cartilage at the rim of the implant. And now we go further, and this was then after HTO, so we did a varus correction of the knee, and here you see the standing x-rays with the straight leg and corrected deformity. And this guy is doing fine, so maybe in future we could use this technique for more patients, not only for single small cartilage defects, but maybe we could extend these indications a little bit, and maybe it could be combined with more digital procedures, maybe with a robot and all the things that are going on. And so let me summarize. We have good clinical short-term results for 2 and 3 episealer implants. I think we have to compare it with the total knee results in this patient group. Malalignment, meniscal cartilage defects are a contraindication. So in my daily practice, I do an arthroscopy prior decision making to be sure that the tibial cartilage is fine and the menisci are fine. And sometimes you have patients that could get an osteotomy in combination with an episealer. And if you think about what is the value of an episealer implant, in my opinion, it's in between these two things. We have the biological repair for young patients, total knee for old patients, and for the best age patients, we have the episealer as one more open option in your toolbox. And maybe it's a little bit too much, but maybe it's the missing brick in the wall. So thank you very much. That's my presentation, and now I would be happy to answer some questions. Thank you very much.
Thank you, Dr. Kösters, for that presentation, and welcome to the Q&A session. I'm going to start off by just asking you to go back to where you discussed in the presentation, namely how you first got in contact with Episurf and why you decided to try the Episealer implant.
My first contact was funny, because I had a presentation on periprosthetic fractures on the Danish National Congress of Orthopedic and Trauma Surgery, and there was Episurf presentation, and there was a guy from Episurf, and so we talked about it, and it was good because I had several patients with these problems, and so that was the first contact. And then I think half a year after this we did the first case.
And you're also an early adapter of Episealer. Can you say what your peers at your clinic says about the Episealer implant, and are they also using it?
Let's say I'm head of department, so my colleagues have to use it. No, but my colleagues like it, and everyone is impressed how good are the results. Also, if we see the patient in our outpatient unit, because every patient comes later to a control, and we include every patient in our study. So we want to collect data, and so my colleagues, my residents, and my consultants, they also use it or use it together with me, and so they are already convinced.
And we know about the typical Episealer patient already, but can you try to elaborate a bit on the typical Episealer knee surgeon, or at least what type of surgeon is more likely to use the Episealer implant than the traditional methods?
Yeah, that's a nice question. In my opinion, the younger guys, maybe also the middle-aged surgeons, like to use this technique more, because it's a progressive technique. It's if you're a little bit more old school, maybe you go for a total knee in these cases, or also if you have cartilage defects, maybe you try again and again biological healings that will not work at the end. And so, in my opinion, you have to be open-minded. You have to be progressive in your therapy. Maybe also a little bit, you have to be kind of a researcher. Maybe you're not a researcher, but maybe it's easier for people who were trained at university, where you know about new techniques, where you have more contact to new developments. And so I think you have to be very open-minded for new techniques, and that's one thing maybe that is different to other surgeons. I don't know.
And do you use Episealer for especially complex cases, or do you use it more widely across the treatment gap patients? And can you elaborate a bit on the typical concerns that patients may have for using this relatively new device?
So let's start with the concerns of the patients. They don't have many concerns. They are really convinced about it when I explain it. The thing is that sometimes you have to stop them a little bit, or to get down sized their expectations, because they hear about custom-made implant, only made for you. It's the newest thing, digitalization, and all the things. So they're very interested, and they think it's really high tech, and it is high tech, but that gives the patients very high expectations. So you have to tell them, okay, but you have cartilage defects, and it's not after the surgery it will be better, but maybe you have some small pain also after the operation. So sometimes the expectations are a little bit too high, in my opinion, and that's important, that you have to downsize this a little bit for the patients. And the first question, sorry, what was it again?
If you use Episealer for specifically more complex cases, or more widely.
Yes, I do. As you have seen, I sometimes combine it with osteotomies, and so I do 2 or 3 implants that I think not many surgeons who use the Episealer do. Maybe I'm a little bit progressive in this, but I have good experiences with it, and the patients are really fine. So I go on this way, and I think it's okay.
And in your personal opinion, what should Episurf do in order to get knee surgeons to start and keep using Episealer?
Yeah, it's you have to be present at the orthopedic congresses in different countries, and there it's important that surgeons like me present their data and present cases and everything, and then in the end we have to publish our data that we collect. We have to publish our results, and if the results are going on like this, I think it's not a problem to make it to make it more public or more common to use it. But in every technique, every new technique, it's difficult to convince some colleagues that this could be a new way for our patients.
And in your view, what competing methods or innovations are the largest threats to Episealer, and what could make you consider using a different method or a product?
You mean other techniques that could be an alternative to Episealer, or yeah, In Europe it's difficult. In the States, maybe you have the possibility to do allograft osteochondral transplantations. That seems to be also a good option, but in Europe we don't get these fresh frozen implants, and so I don't see many possibilities. Alternatives in this technique, because other small implants, they are not patient specific and they are not that exact in the operative technique, so I wouldn't go for other implants.
And my final question, Dr. Kösters, it's a relatively speculative one, but what do you think Episealer's position could look like in 5 to 10 years?
In my opinion, in 5 to 10 years, it will be more known in our daily practice. So I think many more colleagues will know that we have this possibility for maybe failed cartilage surgery to use the Episealer. It will not be like a uni or total knee that you do more and more cases, but it will be more common to use in next 5 or 10 years. I'm really sure.
Thank you very much, Dr. Kösters, for the presentation and the Q&A session.
Thank you very much.